Alright guys, so welcome to week 5 of Chem 646. We're going to go ahead and go through these notes. So here we go. The notes this week are on the effects of exercise on cardiovascular disease. So last week we went over the physiology and pathophysiology of both the heart and the blood vessels. Now we're going to look at how exercise affects that exact pathophysiology. Alright, so an overview of what we're going to talk about. First, we'll just talk about the epidemiology of exercise and cardiovascular disease risk. Talk about some of the cardiac benefits, the vascular benefits, and then benefits and risk factor reduction. Okay, number one, we're going to take a look at a meta-analysis. Like I said, highest level of evidence. As a meta-analysis that looked at the dose response between physical activity and risk of coronary heart disease, so those risk of the heart attack. Dose response means how much exercise do we need to get the best effect, and if we do more, will it be better, and things like that. Yeah, so this was a meta-analysis of all the observational studies that they could find that looked at how active somebody is and what risk of a heart attack they had. So they used the 2008 U.S. guidelines, and what they saw was, how they categorized people was meeting the guidelines, which would be getting 150 minutes a week of activity, the moderate activity, or getting 75 minutes a week of vigorous activity. If they were in the advanced stage, that would be above meeting and do it extra, and that would be getting 300 minutes a week of moderate or 150 minutes a week of vigorous. Okay, or they did it by energy expenditure, which is shown here. They're 500 kcal per week, per minute week, or 1,000 calories per week. Pretty much there was a moderate, a normal level, which just meant meeting the requirements. So they looked at coronary heart disease risk. So the way relative risk works is a 1.0 means no difference in risk. 0.8 would be 20% less. 0.6 would be 40% less. 0.4 would be 60%. It shows that here too. Okay, so what we see, these are all the different studies kind of pooled together. The bigger the dot is, the more subjects there were. So we see most of them trending down, which is good. Okay, most of them, if they were categorized leisure time physical activity with no activity here, and then the further they went down, the more activity they did, the more it kind of trended downwards at a lower risk. Okay, this is looking more at the means here. Okay, so 2,750 calories per week leads to about 20% reduction in heart disease. Even if they were at 1,100 calories per week, they're still right around a 20% reduction in heart disease risk. Okay, this is kind of the pooled activity, again, by the amount of calories per week of exercise, and it looks very similar, right? About a 20% here for the men, but then it's actually once the women get out further, that 2,500 calories range, they get almost a 50% reduction in risk, so a little bit more powerful for the women. Okay, so the conclusion says meeting the minimum recommendation, which is about 150 minutes of moderate per week or 75 minutes of vigorous activity, results in about a 14% reduction in coronary heart disease risk. Going to do the advanced recommendation led to about a 20% reduction in risk. There's even some benefit even below the minimum recommendation, and this relationship was stronger in women, which is interesting. Okay, another interesting study discussed in that Wisloff paper was they had 16 years of following subjects who did just one bout of high-intensity exercise per week. That's all they did, one bout of high-intensity exercise, and the ones that did that versus the ones who didn't had a 39% lower risk for dying of cardiovascular disease for males, 51% lower risk for dying of cardiovascular disease in women. So that's pretty interesting. Just one bout is all it took to get that. And this is from that Wisloff paper. And also jumping into the cardiac benefits of exercise, this paper by Cox showed that 7 weeks of intense endurance training which was 6 days a week of cycling, running at 85 to 90% of max, which was high intensity, led to positive adaptations in left ventricular dimensions in subjects who were sedentary. Wisloff's group has also shown that HIIT leads to about a 12% increase in left ventricular mass, so bigger, stronger heart muscle, and 13% more contractility. Okay, this is a classic study that is one of the papers you read for the week. The Wisloff circulation paper in 2007. It was the first paper to really come out and say, hey look, people with heart failure can do high intensity interval training too. And look, when they do it, they get drastic benefits. So they compared moderate continuous training to high intensity interval training. The moderate training only increased VO2 max by 14%, HIIT increased it by 46%. Okay, ejection fraction was increased by 35% in the HIIT, so it was a huge increase in contractility. Their ejection fraction in the study started at 29%, so these people had pretty weak hearts to begin with. This is that same research group, and what they showed here is how some of those benefits happen. Okay, and they saw that the rate of sarcoplasmic reticulum calcium uptake, which the faster that calcium gets back up into the heart, the better relaxation they have, and they can fill up the heart better. We talked about that a little bit in class last week. No changes in control or moderate training, but a big improvement in the aerobic interval training, the HIIT training. And this has improved calcium handling, and that's really tightly linked to those changes in contractility. We also talked a little bit about the natriuretic peptides, and this is BNP, brain-derived natriuretic peptide. And this one shows a major decrease with the HIIT training, not with the other two types of training. 40% decrease, and that's, remember again, that's a marker of heart failure severity. Okay, there was also a study done through some of my colleagues at ASU who looked at only patients with heart failure with preserved ejection fraction, meaning that their ejection fraction was still high, but they still have left ventricular failure. Okay, and they just did 4 weeks of HIIT versus continuous exercise or standard cardiac rehab. And the HIIT group decreased, so there's a 3-point grading scale for diastolic dysfunction, and that's the heart failure with preserved ejection fraction. And on average, the HIIT group went down from a 2 to a 1. So a 1 is the lowest amount of damage to the heart, and a 2 would be right in the middle. On average, it went from a 2 to a 1 just in 4 weeks of high-intensity interval training, only 3 days a week, whereas the continuous group didn't change their gradient scale at all. So there's a major improvement in heart function. Okay, so the questions are, what are some of the mechanisms? How do we improve the heart function? Okay, one of the things that we see, and so Wisloff's group has done a lot of work with isolated cardiac muscles from rats. They do a lot of work on rats, but then they take those rat hearts out and just isolate single cardiac muscle cells and look at some of the changes they see before and after. One of the things they see is maximal shortening velocity increases by about 60% with high-intensity interval training. Okay, so that faster contraction is a more powerful contraction. We also see that exercise results in just better calcium handling. We already talked about this a little bit. Faster release of calcium from the sarcoplasmic reticulum, leading to faster contraction rates and more powerful contraction. And we get faster reabsorption, so that calcium getting back up into the sarcoplasmic reticulum quicker, which is going to lead to better relaxation and better filling of the heart. We also get increased calcium sensitivity by troponin, which allows for more actin and myosin interaction and stronger contraction, more contractility. So this is kind of a schematic from that Wisloff paper to show it nicely using an isolated cardiac myocyte, cell dimensions. Okay, we have training going up this way, detraining this way. We see cardiac cells get larger, going this way, contractility goes up, and the higher the intensity is, and this one's VO2 max going up, the higher the intensity is, the more these improvements happen. Okay, so besides those other mechanisms, we also see cardiac muscle cell hypertrophy. Okay, you don't need to memorize the details of this. The key is that exercise leads to an increase in protein synthesis, and when that protein synthesis increases, we're increasing the amount of muscle mass inside of each cardiac myocyte, And so we've seen this from the Wisloff group as well. 2 months of HIT training led to a 14% increase in cardiac cell size, whereas 2 months of moderate training only led to about a 5% increase. So they get some with the moderate, but better with the HIT. So in summary, on the cardiac side of things, exercise leads to increased contractility by 3 main ways: improved calcium handling, hypertrophy of cardiac cells, and increased calcium sensitivity. Exercise leads to greater stroke volume by that increase in contractility, but also by an increased filling of the heart. So we get more preload, more contractility, and we get more stroke volume. And all of these changes have been seen to happen more with higher intensity exercise versus moderate. Okay, so we're going to move right into the vascular benefits of exercise. So we see improvements in endothelial function. We talked last class a lot about endothelial function, what that means, and so we see improvements. Here's a bunch of reasons why. We see increased flow-mediated dilation. That's just kind of proof of the improvement. Part of that is driven by increases in the level of nitric oxide after training. So that means that eNOS, that endothelial nitric oxide synthase, is more active and pumping out more nitric oxide. That's a direct measure of endothelial cell health. And so because of that less nitric oxide, we have less cellular adhesion molecules on those endothelial cells. Because we have less of those cellular adhesion molecules, we're going to call in less macrophages and monocytes and leukocytes into the subendothelial space, and we get less inflammation. And we have less oxidative stress because that nitric oxide is working well, and because we don't have those immune cells down there oxidizing things. So that means we're going to get less oxidized LDL. The LDL that is there isn't going to get oxidized, which is going to make the macrophages less likely to engulf that LDL. And then overall, for exercise, we have less LDL, which is going to help us to have less LDL there for the macrophages to oxidize. Okay, so let's look a little bit at this. So in the green paper that you read for this week, there's 2 main types of adaptations in the arteries that he talks about. And one is the functional adaptation, which would be an improved ability to vasodilate under stress. That would be that FMD change. But then he also talks about the structural adaptation, that would actually be the artery size actually changing. Okay. The theory there from the green paper is that the functional adaptations, those changes in FMD, can happen early, maybe after a week or 2 weeks of exercise training, whereas the structural adaptations might kick in later, which would lead to a larger artery. And what that would mean would be when we do an FMD test, if we have a larger artery, that's going to mean less shear stress on the walls, so that might make our dilation during an FMD test actually go down. It's not because they're not healthy, it's because their artery is bigger, right? So both of those effects are probably helpful, but the one that we actually have a lot of data on and we have links to cardiovascular disease risk on is the ability to vasodilate, not artery size. So they're probably both good and helpful adaptations, but the only one we really have proof for right now is the functional adaptation, which is that improvement in FMD. Okay, so a classic couple of papers that really show how well exercise affects the endothelium is by this Hambrecht group. And this Hambrecht group does some really good work. This study here, this 2003 study that was one of the ones you read, this had all the subjects were awaiting coronary bypass surgery. So they're all ready to have bypass surgery. Okay, majorly damaged hearts, major atherosclerosis in the heart, and coronary artery disease. So what they did is the researchers actually went in their surgery to remove this small piece of their left internal mammary artery up in their chest. Okay, and they're going to use that piece of artery to measure some things. Okay, so there was an exercise group and then a control group. The exercise group did 60 minutes per day of exercise, 7 days a week for 4 weeks. So this is a lot, an hour a day for 7 days a week for those 4 weeks. Control patients did no exercise. So in these patients, before and after the 4 weeks of training, they assessed endothelial function directly in the artery by actually putting a probe into the artery, releasing some acetylcholine, which does the same thing as an FMD test, and seeing how much vasodilation you can have. So this acetylcholine response is going to be very similar to the FMD test. It's a nitric oxide dependent vasodilation. And we also took that little piece of artery that they took out before, and then they did it again afterwards, and they used a small ring of that artery, and they put some different chemicals in there to see how much that artery can dilate under stress, just right there in the petri dish. So they kind of had in vitro, which would be in the dish, and in vivo measurements of endothelial function. And so this makes this a very solid study, and they did this with an artery right close to the heart as well. So the results, we saw improved in vitro vasodilation, and then the nice part about having that artery out of the body was then we can actually test the level of eNOS in it, and they saw majorly increased levels of eNOS. So that's a mechanism to show exactly why we have better dilation, is because we have more eNOS, which means we have more nitric oxide. And then we also saw that increase in vivo dilation as well in the body, and this was directly linked to the amount of eNOS increase we saw. So they did a follow-up study after that, where they compared a very common procedure called stenting, where they take a little mesh ring, or kind of like a sleeve almost, and they get up inside of a coronary artery and put that ring in there, open up the artery, so that pushes the plaque out of the way, opens it up, so we can have better blood flow. So they took a group of subjects who had that done versus ones who did exercise. Okay, they followed them up for a year. The exercise group had a lower rate of repeat cardiovascular events than the ones who had the stent. So it pretty much showed that thousands and thousands of dollars can be spent on getting a stent procedure done, or you can just go out and exercise for a year, and you'll do a lot better if you do the exercise. So another great study that you read for this week was the study by Sixt et al. And European Heart Journal 2010. They compared 6 months of exercise versus a control condition in patients with coronary artery disease. They measured actual coronary blood flow. They put a small ultrasound device inside of the blood vessel of one of the coronary arteries, and then they released acetylcholine again to have it vasodilate. And so they looked at how much blood flow they had at rest, how much they had under the stress of acetylcholine, and they did this before training and then again after 6 months of exercise. What they saw was increases in coronary blood flow by about 100% after training. So these subjects doubled the amount of blood flow going through those coronary arteries in response to exercise training for 6 months. So you see the graphs here. You see change in artery diameter. We see that most of them vasodilated. Right? We see percent change in diameter in the control group versus intervention group. Control group, they stayed flat. Most of the ones in the intervention group went up. You can see that most of them were actually constricting in response to that acetylcholine before training. This is all negative, right? That's common in people with coronary artery disease. When you put that blood flow stress or that acetylcholine stress on them, they actually constrict instead of dilate. But afterwards, most of them were dilated. And then the actual just measurement of blood flow, how much blood flow is going in. Control group, we don't see much of a change. Intervention group, we see this big increase in blood flow. Average is about 100% improvement. So major positive improvements directly in the heart itself. Okay, so a study that I conducted, we just published this past fall, or actually this summer, in the Journal of Applied Physiology. This was my dissertation at ASU. This is the lab I worked in for most of my PhD at ASU. This is one of the subjects in the study right here. He was a great guy who made it through the whole study. He happened to be in the HIT group. His BMI was 50 when he started the study. He's about 350 pounds, about 5'10". So what we did for my dissertation was 8 weeks, 3 days a week of exercise on the bike. And there was a HIT group and a continuous group. HIT did 10 1-minute intervals at 90 to 95% of heart rate max, with a 1 minute of recovery between each interval. The continuous group did 30 minutes at 75% of heart rate max, just straight out, so continuous versus HIT. Average BMI in the study was 36. All of the subjects had to have a BMI of over 30, so they all had to be obese, and they all were sedentary to begin. 9 subjects finished in each group, so we had 18. So here's some of the results. We looked at FMD, fluid-mediated dilation. We saw the HIT group go up. There's pre 4 weeks and 8 weeks, up from about 4.8 to about 8.6%. So nice solid increase there. Continuous pretty much stayed the same. This looks like it's going down, but it's not a significant decrease. But we do have a significant difference in the way these groups responded to the exercise. That's what the significant interaction is. Okay. The interesting thing was when we looked at baseline artery diameter, that when we look at that diameter size before we pump up the blood pressure cuff, we just look at that diameter. That's the baseline artery diameter in the brachial artery. What we saw in the HIT group was no change from pre to post, but in the continuous group, it went up. It went up, and now went up significantly. So what that means is we saw not the functional adaptation in the continuous group because their FMD didn't change, but we saw structural adaptation. We actually saw artery growth in the continuous group. Okay, just the opposite for the HIT group. We saw peak diameter go up, so that was that greater ability to dilate. In the continuous group, didn't really see that peak increase. Okay, so just to summarize what I was just talking about in my dissertation study, we saw functional adaptations in the HIT group, structural in the continuous group. So both of those things are probably positive, but the FMD improvements are more tightly linked to cardiovascular disease risk reduction, and so we saw that in high intensity interval training was a little bit more effective in doing that in obese people who were sedentary to begin with. So, a little summary of what we just talked about. The primary stimulus for improving the vascular function is shear stress on the artery walls. And remember, that's that blood flow kind of pushing out against the walls. And what we just kind of went over was direct evidence that shows we see increased nitric oxide production with training. This is due to increased eNOS levels. This improves vasodilatory ability. We also see some direct evidence of artery remodeling. The green paper talks about this, and my study talked about this as well. And then we saw some nice direct evidence of these same improvements happening in the coronary blood vessels, not just out in the brachial artery, but right there in the heart where it counts. And then obviously we also see these changes in the brachial artery. Okay, so lastly we're going to talk about how the risk factors change. Okay, so we've talked about directly about the heart, directly about the blood vessels, but what about all this giant list of risk factors that we have for cardiovascular disease? So we're going to talk about something called the metabolic syndrome, LDL, HDL, blood pressure, triglycerides, inflammatory markers, and blood clotting factors. Okay, so the metabolic syndrome, also known as Syndrome X, puts people at high risk for type 2 diabetes and cardiovascular disease. So the 5 components of the metabolic syndrome are central obesity, meaning increased abdominal obesity, high blood pressure, high triglycerides, low HDL cholesterol, and insulin resistance, most of the time measured as high glucose. Okay? If you have 3 of these 5 factors, then you have the metabolic syndrome. The more you have, the more likely you are to have type 2 diabetes and cardiovascular disease. So this first study by Patin in 2013 in Sports Medicine did a meta-analysis looking at how does exercise help with all of the different factors for the metabolic syndrome. Okay, and so this table 3 kind of shows the overall outcome. We have blood lipids, anthropometric characteristics, glucose, insulin, and then also VO2 peak, which isn't part of the metabolic syndrome. But this shows some good solid mean effects, decreasing LDL by a decent amount, increasing total cholesterol by a decent amount, decreasing weight, BMI, and fat mass, decreasing plasma insulin levels, and majorly increasing VO2 max. So all of these things are helpful for that. You'll want to look into that study a little bit deeper, but that's the primary findings of it. Okay, so chronic exercise training or atherosclerosis. This figure is from that Paul Palmafor's article in 2013. You guys have it's a really nice figure. It's somewhat similar to that colored figure that I printed out for you in class. And that colored figure shows a progression of atherosclerosis, which you kind of see here. This shows all the different risk factors of atherosclerosis, and then these arrows are referring to which way exercise affects them. Okay, so we see decreases in BCAM, ICAM, decreases in CRP, decreases in some of these cytokines, increases in endothelial progenitor cells, which are helpful for repairing the endothelial tissue, decreases in VEGF, which is the vascular endothelial growth factor, leading to that angiogenesis of the plaque. Right, so, and then that Palmafor's article goes into some nice depth on all these changes and the level of evidence that we have for each one. So you want to take a deeper look into that. Yeah, so this study was a study that was already presented in class. April presented this last week. This is that Balducci article. This is the article that really shows more effectively than any other study an overall positive change on the inflammatory status of the body with exercise training, because we see increases in anti-inflammatory cytokines and decreases in pro-inflammatory cytokines. Both of those things are going to be helpful for decreasing overall inflammation, which is going to help with that overall plaque. Same thing here, just some more of those graphs. Make sure to get back into that Balducci article and take a look at those. Okay, another study here that was already presented. This is the one that Brett presented in class, the Corneliuson article, looking at blood pressure. We have two graphs here that summarize this nicely. This is the overall change. Is another meta-analysis on an ambulatory blood pressure. Ambulatory blood pressure is always better to look at than just resting, because this is what your blood pressure is most of the day. It's getting average blood pressure for the whole day. And again, just like Brett pointed out in class, we see an overall decrease of 3 millimeters of mercury systolic and right around 3 diastolic. And this is majorly helpful. And these graphs just kind of summarize, show each study, and then show the mean down here. So this is another blood pressure study that was done by one of my colleagues at ASU, Darnie Balmar, and what she did was compare one 30-minute bout of exercise done in the morning, which is pretty typical form of exercise, to splitting that up into 3 10-minute bouts, do one in the morning, one at lunch, and one in the evening, and see which one had a better effect on ambulatory blood pressure. So we're seeing blood pressure every half an hour here, because it was measured all day. And what they saw was no real change if they just did that one 30-minute bout throughout the day. But if they did the 3 10-minute bouts, we see lower blood pressures all afternoon and all evening, as shown by this line here. And so this kind of shows that blood pressure, since there's this acute effect of blood pressure decreasing with one bout of exercise, if we split that one bout up into 3, we'll have that acute effect giving us benefits all day long, which can be very helpful. Okay, another study here is a great meta-analysis on blood pressure overall. This is by Robert Fagard, and the purpose of this was to assess the characteristics of an exercise program on how much blood pressure decreases. Okay, so this is what we're talking about. Is intensity the best thing? Is volume the best thing? And their design was a meta-analysis. Okay, so they found 44 randomized controlled trials that included 2,700 subjects. The subjects were, you see their age there. The interventions were 4 weeks to a year, 1 to 7 days of exercise. Most of them were about 3 to 4 days a week, 30 to 60 minutes per day, walking, jogging, running, some cycling, a little bit of swimming. That just kind of shows all the different characteristics. So what they saw overall, the change in response to training, not looking at the intensities yet, we see the net change about 3.4 millimeter decrease systolic, 2.4 millimeter decrease diastolic, see an increase in VO2 max, and so those are all very positive changes. But probably the most interesting part, again, we've got these. So in normal intensive people that don't have high blood pressure, we see about a 3 to 2 millimeter drop in blood pressure, so 3 millimeters systolic, 2 millimeters diastolic. But if people have high blood pressure, we actually see a much greater effect. We see about 7 millimeters systolic, about 6 millimeters diastolic. So it's more powerful for people that have high blood pressure. So of all those studies that they found, there was no convincing evidence that exercise of a higher intensity is better for blood pressure. So they compared 40% all up to 70%, no difference. Okay, what they did see was that 3 to 5 days a week, at 30 to 60 minutes, all had similar effects on blood pressure, so it didn't matter if you went 3 days or 5 days. But if you went 7 full days instead of 3 to 5, then that is actually better. So there might be an issue of volume being the most important thing for blood pressure here. The STRIDE trial also showed that same thing, that volume is probably the most important factor for blood pressure, just like it was for cholesterol, which we'll look at in a second too. So intensity doesn't seem to be the factor for blood pressure, but volume does. Okay, so here's the STRIDE trial that I was just talking about. This is the one that Rebecca presented in class. The study by Krauss, looking at all these different types of exercise on cholesterol reduction. Okay, so there's 4 doses of exercise. 1 is just no dose, the control. 2 is just like Rebecca explained, 12 miles per week of walking. This one, low volume, high intensity, 12 miles per week of running. Or we have high volume, high intensity, 20 miles per week of jogging. Okay, so again, the one we're missing is the high volume, moderate intensity, which would have been 20 miles per week of walking, but that just would have taken so long that they didn't include that group. So just like Rebecca showed, this is what they saw. Volume was key. Right? We have 2 groups doing high intensity, and then 1 group doing low intensity. Low intensity group didn't have many improvements. A little bit of a change in IDL, LDL, nothing. We see a nice decrease in that high volume group. There's only 1 high volume group, right? So even if you compare the 2 high intensity groups, doesn't matter, the volume was key. Much better change in LDL, change in size of LDL particles, change in the concentration of LDL particles. And then we got the same thing with IDL here, which is another one that's bad for you. They all go down, but the high volume goes down the most. Okay, same thing with HDL. The only one that had a real strong effect on HDL was the high volume. Okay, we want HDL to go up. Same thing here. All these HDL factors are showing very positive results. But again, volume is key, not intensity. Okay, so here's the conclusions. Rebecca showed the same figure here. But the key volume of exercise was key, not intensity. Okay, another meta-analysis here that looked at the effects of exercise on HDL. You can see what they did. Started with 109 studies on HDL, boiled it down to about 25 studies that they could include. Here's a nice figure that shows all the studies used, and you can see this red line represents 0. Okay, so anything to the right of this red line means HDL went up, which is what we want. Anything to the left means HDL went down. Here's the mean down here. We see is about a 2.53 increase in HDL cholesterol, which is significant and very key. Again, they looked at was volume more important or is intensity more important? Again, these authors came with the same conclusion that volume is most likely the key factor, not intensity. Okay, and this is most effective. The interventions were most effective if subjects started with high total cholesterol to begin with, and their HDL went up more effectively. Okay, this is just this is that figure that I've already showed you, right? And so what we see here is we see that progression of atherosclerosis. So what I'd like to do is just kind of show you in a summary format all the different effects of exercise. So let's go ahead. So number 1, we increase shear stress with exercise, and that increase in shear stress stimulates endothelial cells to be more healthy. We get an increase in the endothelial nitric oxide synthase, which that gives us the ability to produce more nitric oxide, which increases vasodilatory ability. Okay, and we also, by making the ENOS more healthy and more effective, we release less free radicals and we don't oxidize LDL as much. Okay, number 2, exercise is going to decrease the amount of total cholesterol and LDL in the blood, so that's going to lead to less LDL here. Higher HDL levels. HDL has been shown to be anti-inflammatory as well as help us to lower LDL, and then we decrease triglycerides, which also helps with the amount of fat we have built up in the artery. Okay, next we got decrease in VCAM, ICAM, and E-selectin. Okay, those things are what are this vascular cellular adhesion molecule and intracellular adhesion molecule. These are the things that are calling in the monocytes, calling in those T cells to start the inflammatory process. So the less of those we have, then the less immune system activation we have. And remember, these are stimulated by, or they're inhibited by NO. So we went back to that first change. If we have more NO, we have less of these. We're going to end up with less macrophages and less inflammation. Okay. We also there's also evidence to show that exercise will decrease the amount of MMPs in the body, and really kind of get the right ratio. And we see the MMPs shown here. These MMPs kind of break up some of the plaque area, but they do it in such a way to where it makes that plaque less stable. The less stable it is, the more likely it is to rupture, the more likely we are to have a heart attack. Secondly, we see exercise decreases fibrinogen. Fibrinogen is one of our main clotting factors in the blood. It's right before we turn it into fibrin. So the more fibrinogen we have, the more likely our blood is to clot. We also decrease a molecule called PAI1, which is plasminogen activator inhibitor 1. Pretty much this means that we break down clots that form more if we have less of this here. Okay, and all of this stuff is in that Gazer review article that I said you should look at. It's an article I had a chance to work on with my mentor at ASU. There's a lot of good effects of that, and the MMPs, fibrinogen, and PAI1 are all discussed in that Gazer article. Okay, other things: exercise increases HDL, which decreases plaque, decreases inflammation. Exercise decreases blood pressure, which improves endothelial function. Decreases blood glucose, which means we don't glycosylate the endothelial cells and damage those. Decreases pro-inflammatory cytokines. Here's a bunch of those listed here. Also increases anti-inflammatory cytokines. Here's 3 of those here. And a lot of this stuff is found in that Gazer article, as well as that Balducci article.